Hi everybody, thank you guys so much for coming to this education. Virtual education is not nearly as fun and as exciting as inline or in-person education, but we're going to do the best we can in this COVID world. We are learning that we have to tuck and roll. So I will tell you, this is like the third time we're videotaping this, so we're just going to go straight through and you guys can feel free to laugh at our gaffes and our mistakes. So again, my name is Terry Campbell. I'm the flight nurse at the University of Chicago. I've got a wonderful team of my peers that are going to be assisting me with this education. So the education modules that we're covering is neonatal resuscitation. So in the ED, the two most common circumstances are the patients that come in and precipitously deliver, which is completely rude. They should make it up to labor and delivery, but that's another story. The second time that we need to have these resuscitation skills are the parents that are bringing in these newborns that are in extremis. So both of these situations are extremely stressful. So we are just going to break it all down into steps. We're going to go through it slowly and we're going to hopefully take away some of that pucker. So we're going to start with Mindy and she's going to talk about correct mask selection, and then Brenna's going to talk to you about the correct way to bag a baby.
Thank you, Terry. So when it comes to sizing the mask for your baby, we want to make sure that we have the correct size so that we are opening the airway correctly. So you're going to find that you have different sizes. This first one, I just want to show you that if we were to choose this one, it's going to be a little bit too small. If I press down to try and make a seal, I'm smashing baby's nose. And if we have one that's too big, you'll see that we are covering the eyes, smashing down a baby's eyes, and it's not going to be a good seal. So if I use this one here, we want to press down a little bit. We want to pull the jaw up and bring baby's face more to the mask. We don't want to smash the mask down on baby's face so that we can correctly open that airway and give good ventilations.
So then you're going to need an appropriate sized infant bag, a manometer, and also a PEEP valve. A lot of people forget the PEEP valve with the little ones, but it's just as important as using it for an adult. We'd like to retain any of the pressure that we get when we recruit the lungs. So here, that opening pressure we want to be between 20 and 25, and then NRP recommends continued pressure between 15 and 20. If you're in the green zone, you're getting adequate chest rise. That should be sufficient, but just make sure you're giving enough pressure to actually move the infant's chest. So now we'll go ahead and give this a try. All right, and let's look for chest rise. We're really not seeing much of a chest rise. So at this point, you can think that maybe the position could be off. So for this baby, there's no shoulder roll. So Mindy, I'm just gonna, if you'll assist me, lift it up, and we'll put a shoulder roll under this little babe. Okay, so we have a nice shoulder roll that's not too thick, leaning the head back. We want to get in that good sniffing position. All right, let's see what we can get here. Up, and we see if you can, I hopefully appreciate, we do have a good chest rise now. That means we have a good mask seal in the bag. So the ways that we're going to bag, an easy way to remember it, is that it's kind of like a waltz. It's squeeze 2, 3, squeeze 2, 3, squeeze 2, 3. So if you kind of think of that waltz metric in your head, hopefully it will help you keep the bagging at an appropriate rate.
Okay, great. Thank you, ladies. So now we're going to have Kyle and Candace come over, and they're going to talk to you about the fine art of doing compressions on a baby, and also that very panicky, oh my gosh, how am I going to draw up drugs?
Okay. So for doing compressions, if positive pressure wasn't effective for our baby and they become bradycardic, we're going to create a nice base while encircling with our hands, place our thumbs between the nipples, and we're going to squeeze at a rate of 120 at 1/3 the diameter of the baby's chest, which is a little bit deeper than it would feel. So it looks like this. 1 and 2 and 3, breathe. 1 and 2 and 3, breathe. 1 and 2 and 3, breathe. 1 and 2 and 3, breathe.
Okay, and if things still aren't going well, we're going to have to move to medications. So when we get to this step, we're oftentimes very nervous, right? We're going to use the same code dose epi you use for every patient population, so 1 to 10,000 or 1 milligram for every 10 mLs. A great tool to have is a stopcock, and I know that we don't use these a ton in the ED, but if you can just remember that the direction you point the stopcock is off. So you're going to point it off to the patient port, and you can put your epi on one end and then a small 1 ml syringe on the other. Now, dosing for a little person is going to be 0.1 mLs per kilogram. So if we have a 5-kilo baby, it's going to be 0.5 mLs, and we can just use our stopcock to help us drop the appropriate amount of medication. Now, right now, we don't have a line in this baby, so we could discuss potentially using ET tube dosing, which would be 0.3 mLs per kilo. However, that hasn't really been proven to be that helpful in terms of resuscitating babies. We'd much prefer to have a line. So we're going to talk about that next.
Okay, guys, so now we're on C for circulation. So we're going to talk about inserting an IO first, because that is more common in the ED than putting in a low-lying emergency UV line, but we will talk about that next. So let's talk about landmarking. So you guys know from assessing IO landmarks for your adult and your pediatric patients, you're feeling for that tibial tuberosity under the patella. But our little neonates, they don't own a tibial tuberosity because that's something you develop after you start ambulating. So our landmarks for our baby is we're going to bend their little chunky legs, we're going to find their patella, we're going to go 1 finger breadth below the patella, 1 finger breadth medial, and that's going to bring us to that nice flat plateau of the tibial tuberosity. Now, I'm going to say something that's going to make you really panicky. When you're putting in your IOs, I actually personally recommend that you do it with your eyes closed. I'm not telling you that Teleflex or any of the other manufacturers say that, but this is a tactile skill. I've seen it over and over where people are drilling the IO, they see that needle drop when it goes into the interosseous space, and then they recoil and they pull it out. So the first time that you drill, with your eyes closed, do I want it to be on a baby? No, but practice on sawbones, practice on eggs, which Mindy is going to show you in a second. So the other landmark that we can use is distal femur. Great landmark. So again, bend their little fat leg, find that patella, 1 finger breadth above the patella, 1 finger breadth medial. That's going to be your landmark. Now your pearls for this is their quad muscle, those little roly-poly legs, they're probably going to need a longer needle. So again, when you're picking your needle selections, I always say if it's as thin as over your wrist, you can probably get away with the pink needle. If it's as chunky as your forearm in comparison with their leg, you're probably going to need that blue needle. But remember, you're going to pierce through the skin first, resting on the bone, check for that black line. That's how you're going to know if you picked the right needle. If you see the black line, you picked the right needle. If you didn't, you need to get a longer needle. So again, for the distal tibia, you're probably going to need a longer needle. The other practice pearl is that this leg now needs to be on a little arm board. If we have flexion and extension of this leg, it can back out the needle, particularly in the distal femur. So again, I also strongly recommend that you use the manufacturer's triangular dressings so it stabilizes and it stays put. So Mindy now is going to show you the technique. When you're drilling for a baby, you don't need to push. Remember, our babies are a little deficient on epinephrine, but we've got way more than we know what to do with. So we have to be careful that we're not pushing because we can go through and through that bone. So Mindy's going to show you a great demonstration here using an egg. So Mindy, why don't you talk about how you're going to do this here?
So what I'm going to do is I'm going to put the needle in. I'm going to find my landmark. I'm going to put the needle in just as Terry talked about, and I'm going to make sure that I have the black line. If I don't see the black line, then I've got to get a longer needle like she had mentioned. So the egg doesn't appreciate having skin on it, so it really is, I would put the needle in to the skin until I reach the bone, and then I'm going to drill turn the drill on, and I'm not going to push, but I'm rather going to let the drill and the needle do the work for me.
Perfect. So as soon as Mindy felt that loss of resistance, she just took her finger off the trigger. So there can be a gap between the skin and the base of the needle, and that's fine because that's why you're going to be using that stabilizing dressing. So can you pull that needle out? So if the camera can see, our egg has lots of holes on it because our team has been practicing. And look, The shell has not been broken at all. So that's the beautiful thing. You don't have to worry about breaking your baby. Okay, so now we're going to accelerate this. Brenda's going to come over and we're going to talk about how to place an emergency UV line, a low-lying umbilical vein line placement. So again, this is not commonly a skill for emergency room nurses. And again, even though we're going over all of these great little practice pearls, I do want to strongly recommend that people take the official NRP class. So our little videos are not certifying you in NRP, but they are giving you some good practice pearls. So this umbilical cord is actually quite long, but it's a very expensive simulation model, so I am not going to cut this because I'm sure I would be strung up. So Brenna is going to support this for me. And again, as ER nurses, this is what we would be doing to be assisting. So most likely there would be a yellow cord clamp that may be on the end of this umbilical cord. We don't have a cord clamp remover, and we also want this cord to be a little bit lower. So probably if this was a real cord, I'd be cutting it so it was about maybe 1 inch to 1.5 inches long. I'm going to take a scalpel. I'm going to make a clean cut across the top. Brenda's going to be holding it with 2 hemostats so we can maintain that sterility and maintain some rigidity of that cord. I'm then going to be using a betadine. So we don't want to use chlorhexidine on babies. So I'm going to be using betadine. I'm going to be painting not only the top of the cord, I'm going to be painting up and down all the way around the cord, making this as clean as possible, giving that a few seconds to dry. While I'm letting that dry, I'm going to be assembling my UV line. So I'm going to be attaching a syringe to it. I'm going to be flushing it. And again, we're doing this in the sim lab during COVID, so I don't have all of my supplies. But I would ideally have another sterile either hemostat or something that I could hang onto my umbilical cord with. So I'm going to pull it out, trying to maintain that sterility. And again, obviously I'm going to be having sterile gloves on it. Now, to find our landmarks, on the nice simulation model, it's super easy to see. In real life, it's not always as easy to see. There are 2 umbilical arteries and 1 umbilical vein. The vein is the larger of the vessels. And in neonates, remember through the umbilical cord, it's the opposite. So the vein is what's been carrying the oxygenated blood from mom to the baby. So I'm going to take this, and again, painting it with the betadine is going to make it easier. Brenda's going to hold it straight up for me. Oh, you know what? I'm sorry. I forgot a very important part. Now that I told you this, I forgot a very important part. Brenna, can I have you tie on?
Yeah, absolutely.
So again, real life here, right? So the very first thing I should have done was tie this umbilical cord tie. And I want it to be tight enough that when I make my cut, it's not going to bleed, but not so tight that I can't pass my catheter. So let's back Terry up in her brilliance. So we're going to tie the umbilical cord first. Brenna is going to be supporting that cord. I'm going to make a fresh cut. I'm going to be painting. Then I'm going to make my fresh cut. I'm getting myself all flustered here. I'm going to find my landmarks, and then I'm going to thread in my umbilical vein. So again, just like with this model, as with real life, sometimes it's difficult to get it to go in. So holding that cord up straight is going to make it easier. I'm going to keep inserting until I have a flash of blood that's going to come out. Now, if you have a physician here, the physician can suture this. That's going to hold the line. If it's just you and you're doing the best that you can, or your physician's not comfortable suturing it, what we're going to do is we're going to lie the umbilical cord down. We're going to coil it on the baby's tummy. Okay, can you get that?
Mm-hmm.
Okay, perfect. And then I'm going to use my opsite dressing. I'm going to secure the cord down like this. I'm sorry, my line down like this. And then, since I've got such a long umbilical cord, I would honestly take another OpSite and I would secure it like this because I want to make sure that it doesn't go anywhere. And then, as Candace brilliantly demonstrated with the stopcock, we can add our stopcock to the end of our catheter. We can give our drugs, we can give our fluids, we can give our blood products. So that's it on the umbilical lines. If there's any questions, let me know. Again, I apologize. Remember, the cord tie first, securing the cord, painting it, making a fresh cut, identifying your vessels, and then inserting the catheter. So I apologize for my gaffe there. Okay, guys, any questions? Thank you.